Hi all, myself Deepika from SNS College of Allied Health Sciences from the Department of Radiography and Imaging Technology. Here I am going to discuss a case study on X-ray forearm with wrist AP and lateral. Here comes the patient details. The patient name is Mrs. Devaki, aged 62 years, female. Who come with a history of cell-fall injury. The physician suggested to take an X-ray of right forearm with wrist AP and lateral. So if a patient comes with a forearm injury, we have to take AP and lateral. So here is the position of the patient and the cassette. The patient is seated alongside the table with the affected arm nearest to the table as like shown in the image, and the arm is abducted and the elbow is fully extended with the supinated forearm resting on the table, and the shoulder should be lowered to the same level as the elbow joint. The cassette is positioned under the forearm to include the wrist joint and the elbow joint. Arm is adjusted so that the radial and ulnar styler process and the medial and lateral epicondyles of the humerus are equidistant, and lower end of humerus and the hand are immobilized using sandbags. So we have to center at midway between wrist and elbow joint, so covering the wrist joint and elbow joint. So in case of forearm AP, we have to give X-ray image including the elbow joint and wrist joint. So here comes the forearm lateral. So forearm lateral, from the anteroposterior projection, the elbow is flexed to 90 degrees as shown in the image, and the humerus is internally rotated to 90 degrees to bring the medial aspect of the upper arm, elbow, forearm, wrist and the hand into contact with the table. So the cassette is placed at the forearm in order to cover both the elbow joint and the wrist joint as I discussed in forearm AP. So the arm is adjusted such that the radial and ulnar styloid process and the medial and lateral epicondyles of the humerus are superimposed. So in case of lateral projection, to get a true lateral, we have to make the patient a correct 90 degree angle of the forearm to get medial and lateral epicondyles of the humerus or superimposed on each other. So the lower end of humerus and the hand are immobilized using sandbags if needed. So we have to center at the midline of the forearm to a point midway between the wrist and the elbow joint. Essential image characteristics, in the sense we have to cover in case of forearm lateral, we have to cover both the elbow and the wrist joints on the image. So here comes the technical factors. The image receptor size is 24 into 30 centimeter and 18 into 24 centimeter, which is a cassette size, and the orientation of image receptor based on the patient projection. Based on the projection we are taking, we have to change the orientation of the image receptor. So in case of single hand we are taking, means you have to keep in portrait, and if you are taking for two hands X-ray, means you have to keep the cassette as landscape. Exposure factor is KVP and MIS, which determines the quality and quantity of X-ray we have to give to the region of interest. So KVP and MIS for the forearm is 50 to 55 and 2 to 4 is sufficient. FFD is nothing but focus to film distance, which is 100 centimeter, and grid we will not be using for extremity radiography, and radiation protection gonadal shielding must be employed in order to avoid the patient getting the scattered radiation. It also depends on the department policy. And here comes the X-ray of the patient. The left side shows the right forearm AP and the right side shows the right forearm lateral of the patient showing a fracture. So the findings is that mildly displaced oblique fracture is seen in the distal shaft of ulna. There is a fracture at the shaft of ulna and the radius is normal. Elbow wrist joint appears normal. Soft tissues are unremarkable. This is the finding given by the radiologist. And next is the impression. The main thing is there is a displaced oblique fracture in the distal third of right ulna. So here in this image you can find that there is a displaced fracture in the ulna, showing oblique fracture in the ulna. So this is how forearm AP and lateral projections will be taken. And here are my references: Clerk's Positioning in Radiography and Concise Guide on Basic Radiological Physics, Darkroom Procedures, Radiographic Positioning and Techniques by Latit Agarwal. Thank you.